Good
Thank you,
evening.
Professor Cooper, for that very crisp and clear presentation on the treatment aspects of hypothyroidism. I mean, you answered most of the questions and the discussion points also. I mean, from
Okay.
Jaipur and all covered a little bit of our questions, but questions from our delegates. The first one is about you spoke about how suppressive therapy is needed in differentiated thyroid carcinoma. So, when you say about suppressive therapy, are we looking at TSH cutoffs or to keep the T4 within normal limits? Where do we look at both?
We don't look at both. It's really the TSH that we care about, since it's TSH that potentially could stimulate the growth of whatever residual thyroid cancer is there. And so, to be honest with you, though, the concept of suppression therapy has really undergone a lot of changes over the last few years, and people recognize now that it doesn't need to be very aggressive. And this idea that the TSH has to be less than 0.1 in a person with thyroid cancer just isn't true. And randomized trials have even shown now that maintaining just a normal TSH level in most people leads to the outcome that's no different than, having a low TSH in terms of recurrence and mortality. So I think for the average thyroid cancer patient who, let's face it, most of them have low risk disease, the TSH doesn't need to be suppressed at all. I think just a TSH of between 0.5 and 2 suffices for the vast majority of thyroid cancer patients. In people with
Then
advanced disease, let's say, but I'm sorry, but if you have advanced disease or distant metastases, yes, then you want the TSH to be less than 0.1, I think.
So a low or moderate risk of recurrence, then you would like to keep it between 0.5 to 2, and aggressive disease, high risk of recurrence, you would go for less than 0.1.
Yes. In a person who's not elderly, then you have to balance the risks and benefits, obviously.
The next question is about in pregnancy, when you have the TSH between 2.5 and 4 with antibody negative status. So do you
Mhm.
treat or do you advocate treatment or just observe?
I didn't really get into the details of this because it's so controversial. There's really no answer here. I think that most people think that in a person who doesn't have anti-thyroid antibodies, a TSH up to 4, if they're pregnant, is probably okay, because that's probably the upper limit of normal for women who don't have a thyroid problem. But emotionally, I think most of us would probably want the TSH to be not between 2.5 and 4, but between 0.5 and 3, I think. But there's just no evidence that doing that is going to change the outcome. Really. I mean, there are some studies that suggest that it might decrease the risk of miscarriage in one study from Iran, but from other larger studies, it doesn't seem to matter. So there's conflicting data. The American Thyroid Association is coming out with guidelines for the management of thyroid disease in pregnancy probably next year. And this will be, but I just heard a presentation a couple of weeks ago at our ATA meeting, and they're going to actually relax things so that they're going to accept a TSH up to 4 in most people.
What about the lower limit of TSH in pregnancy? How low? I mean, you are keeping it less than 2.5. How low can we go?
Well, because of HCG stimulating the placenta from the placenta, it stimulates the thyroid. It's actually normal for pregnant women who don't have a thyroid problem to have a low TSH, especially in the first trimester. So about 10 or 15% of all normal women have TSH levels that are less than 0.5 or even less than 0.2 in about 5% of women. So I think having a TSH that's, between 0.3 and that would be about as low as you'd want it, maybe 0.2 even. And then as the pregnancy continues, TSH levels in normal women go up a little bit. But I think anything between 0.3 and 2 is satisfactory or 2.5 in a pregnant woman.
You touched upon it on your talk, the T3 therapy. So there are a lot of questions regarding T3 from our delegates in Trivandrum. So basically, are there any real evidence-based indications for starting T3 in hypothyroidism?
Well, when you talk about evidence-based, I mentioned there are at least 12 randomized controlled trials where people are blinded as to what they are receiving. and they're either receiving T4 plus placebo or T4 plus T3. And then the period, let's say 3 months, then they're switched to the other treatment. So these are crossover studies in addition to being randomized. And then people are given complicated batteries of mood questionnaires and symptom questionnaires, quality of life questionnaires. And the bottom line is that it doesn't seem to matter what treatment the person is on. There's really little evidence they feel differently taking T3. But, and here's the big but, if you ask them, what period of time did you feel better? In other words, period A or period B, the majority of people feel better in some non-specific way when they're taking T4 plus T3. Now, in other words, this is something that we cannot measure. It is not brought out in these complicated measures of quality of life, but people just seem to feel better in some way. So so you could say, well, we had 12 randomized trials. It doesn't work. Why are you even talking about this? Because this is a persistent, issue in terms of patient first demanding it in some cases, but also just in terms of research, there may be something to this. And as I said, it may be in a small subset of people that have some defect in transporter or in T4 to T3 conversion, the polymorphisms of the enzyme. So some people may not convert T4 to T3, and those specific groups of people have not been studied. The only, it's just large groups of people with hypothyroidism, not specifically looking at people with, congenital, slightly lower T4 to T3 conversion capabilities.
Do you have any opinion on the weekly once levothyroxine? In some people who have, unsuppressed TSH, and most likely it is they are not taking it properly. So is that considered as an alternative, weekly once combining the doses?
Yeah, I mean, as a last ditch effort to treat the patient who's not compliant and not taking their medicine, or in a person, let's say, who's, in a institution and, or, living in a group home or something, you could do this. And it would result in, relatively normal thyroid function, but it's not ideal, but it's a last, just effort, I would do it. I mean, you might do it twice a week instead of once a week or something like that. But yeah, I mean, sometimes it's rare, but yes, you have to do that.
And last question from our side, primary hypothyroidism, follow with TSH alone or TSH with free T4 or total T4?
I think it's fine to monitor the TSH alone to be cost effective. You don't need to monitor the free T4.
Thank you, Professor Cooper, and I think I hand
My
over back.
pleasure. Thank you. Thanks for your attention. I appreciate it. Have a good evening.
Hi. So excellent presentation, Dr. Cooper. I think you have covered the entire spectrum of subclinical hypothyroidism to T4, T3 combination to how you can give thyroxine as a whole to elderly people. So everything has been covered. So we have, I think everything has been discussed from our previous centers, but we have a couple of questions, and especially with the your topic on T3, actually, T3. So one of the question was like, can we give this oral T3 preparation in myxedema coma? Because here in India, we don't have intravenous preparation of levothyroxine and all. So what's the role of that?
So in people with myxedema coma, this is a complicated subject, but obviously the treatment emergently would be to give a large dose of levothyroxine intravenously, usually 300 to 500 micrograms, which will replete the thyroid hormone levels in the body at a low level, and then to give the normal replacement dose IV every day from that point on. Now, there are some studies that show that in some people with myxedema coma, they do not improve after doing this. And that would be the reason to give T3, IV or PO in people with myxedema coma who, after, let's say, 2 or 3 days of IV levothyroxine therapy, have not improved. They're still on a ventilator. They're still critically ill. You might give them 10 micrograms of T3 2 or 3 times a day. There are experts who believe that T4 plus T3 therapy should be given at the beginning of myxedema coma therapy. because the problem is that if you're critically ill, you don't convert the T4 into T3. I mean, that's the whole point of, your body shutting down, and you want to maintain metabolism. So a defense mechanism is making less T3, but that may be harmful in people in myxedema coma. So there's a controversy about the emergency management of myxedema coma. The conventional treatment would be to give a big dose of T4 IV once, and then every day IV the normal replacement dose. But a new set of thinking is to give T3 plus T4 from the get-go. There are no randomized trials where they have compared these two regimens. And of course, the mortality rate is pretty high, no matter what you do. It approaches 15 or 20%.
Correct.
So do you have IV T4 in India?
No, it's not available. We have
Well,
the oral T4 and also the T3, which has been available.
yeah. So when you treat myxedema coma, you treat them through a NG tube?
Yeah.
Yeah. Well, we have IV T4. We don't use it hardly at all, except in hospitalized patients, but it's extremely expensive. So I think 1,000 microgram vial, which would last maybe 2 days or 3 days, is $1,000 US. So it's very, very expensive.
Very expensive.
Yeah.
So another question in that line is that I think in Jaipur, they have asked about surgical clearance with high TSH. So is there any role of giving T3 for rapid correction, and then you can go for surgery?
I don't think that that's usually necessary. As I said, I think that for the average person who's having, just scheduled surgery, the surgery can wait until their thyroid levels are normal. If it's more emergent, you should do your best to normalize thyroid function tests with levothyroxine. But in fact, the outcomes of surgery, when you compare them to people who are hypothyroid inadvertently, who went to surgery without even knowing that they were hypothyroid, versus euthyroid people, most people do okay. So you shouldn't have this, fear that the person's hypothyroid and they're going to have some bad outcome. I mean, it may be that they won't wake up quite as quickly from the anesthesia, or maybe their blood pressure will be on the low side, or maybe their PO2 will be low, but most people do okay. It's really hyperthyroidism and going into surgery where that could be catastrophic because of atrial fibrillation and myocardial infarction. So if the TSH is 5 or 10 and the person needs to have a knee replacement, I think that would probably be okay, honestly.
Right. So another thing is that someone has asked we have discussed everything about subclinical hypothyroidism, like more than 65 years, less than 65 years. What about the adolescents or children? Is that criteria still holds good, and the therapeutics also is similar?
For children?
For subclinical hypothyroidism.
It's funny. The pediatricians have a different view than I do about this. They seem to be more cavalier than I am. I think, if you have a 10 or 15-year-old kid who has subclinical hypothyroidism, I think that person ought to be treated. That's all I have to say. I mean, they're just not normal. And if you're growing and developing, I think it would be appropriate to treat that person.
Absolutely.
But some pediatric endocrinologists think it'll resolve on its own. That's why they don't treat it. They think it's just a phase or it's temporary, which may or may not be the case. The other thing I would say is that in the pediatric population, some kids who have a high TSH, they have underlying autoimmune thyroiditis, they have a goiter also. And treatment decreases the size of the thyroid because the TSH is being lowered. So I think if the person has a goiter, that's another reason to treat them.
Absolutely. So currently with the immunocheckpoint inhibitors, as you have touched, so thyroid dysfunction can happen. So what should be the usual checks? So how frequently one should check if someone is on immune checkpoint inhibitors?
Well, this is more for the oncologist, not for us. But and I think they have guidelines for what to do when they start a patient on an immune checkpoint inhibitor. But I think they check thyroid function tests before they start. And then I think they should be checking thyroid function tests every month, probably for the first 6 months, because it happens usually very quickly. It's autoimmune thyroiditis that they develop. I mean, occasionally people develop Graves' disease, but mostly it's autoimmune thyroiditis. So they become mildly hyperthyroid followed by hypothyroidism that can be permanent. So like the typical, subacute thyroiditis picture, or they just become hypothyroid. But it happens pretty quickly, usually within a month or two of starting the drug.
Thank you. So another last question is, one doctor has asked about your comments on thyromimetics, especially in use in MSLD.
Yeah, well, that's a really exciting area of research. This is not a new thing. This was discovered even 10 years ago. People just, had these compounds that could act specifically on the liver as a treatment for dyslipidemia, but there were side effects, so they were withdrawn from the market, and now they have these new drugs. And whether these drugs specifically are taken up by the liver and they just don't get into other tissues, or whether they just get taken up by the liver better than other tissues is not known. But yeah, it's and they act on the thyroid hormone receptor to mimic the effect of thyroid hormone, which increases metabolism in the liver specifically, which is a treatment for fatty liver and fibrosis. So that's a really exciting field. Yeah, I don't know. I don't know anyone in my country who is using these drugs yet. I'm not even sure they're available commercially yet. But yeah, it's a very exciting development. Yeah.
Thank you.
Okay. Thank you so much. Good evening to everybody. Thanks for your attention.